Well, good morning. And welcome to Department of Psychiatry Grand Rounds. I'm Tom Strauss, and it's my great privilege to introduce today's Grand Round speaker, my friend, colleague, and mentor, Dr. Michael Gitlin. As many of you know, Dr. Gitlin has been a luminary in North American psychopharmacology for many decades. He is at present Distinguished Professor of Clinical Psychiatry here in the department at UCLA, where he completed his residency training in 1979. Dr. Gitlin has been director of the Division of Adult Psychiatry since 2003, medical director of the Department of Psychiatry's practice plan since 2007, and has held a number of other leadership roles during his time as full-time faculty member at UCLA. But perhaps his greatest and most enduring contribution has been as director since 1985 of the UCLA Department of Psychiatry Mood Disorders Clinic. Co-founded with Kay Redfield Jameson, the Mood Clinic has been an extraordinary training setting for literally generations of residents, providing superb clinical care for patients with treatment-refractory mood disorders at a level really not available in the community. Dr. Gitlin's work has also earned him a number of campus and regional teaching awards and has included formal recognition by the American Psychiatric Association with Distinguished Life Fellowship status and other honors. As a clinician scientist, Dr. Gitlin has been PI or co-PI in multiple extramurally funded clinical trials, which are trials of great practical importance to patients and clinicians alike. And Dr. Gitlin has delivered literally hundreds of CME lectures in the community and at national and international meetings. He has also authored 5 books on topics in psychopharmacology, including, along with Michael Bauer, the most current and comprehensive review of lithium available in the world, and has written more than 160 peer-reviewed journal articles and book chapters. We at UCLA are luckiest, however, to recognize him as a consummate educator who brings together his passion for clinical psychopharmacology and his supreme teaching skills to the benefit of our greater learning and caring community. He's the principal teacher of our adult psychiatry residents in the epidemiology and state-of-the-art biological therapies for depression and bipolar disorders, and his talks, like fine wine, continue to deepen and develop complexity as he tweaks them with cogent, incisive updates based on the best emerging literature, and most importantly, as a practical, concise, funny, and rigorous clinical thinker. So these characteristics, I think you'll agree, will infuse today's talk on the psychopharmacology of borderline personality disorder. I know you'll learn from it, and I look forward to our discussion at the end. Dr. Gitlin.
Thank you, Dr. Really, the first time I've been compared to wine. I'm honored. So what I want to talk about today is exactly that, how to think about creating an algorithm or way of thinking about constructing medication paradigms with people with borderline personality disorder. And you may wonder why a mood guy is going to talk about this. And the answer is because the Mood Disorders Clinic has a ton of borderline patients. Now, why would that be? Turns out that 85% of patients with borderline personality will have a major depression at some point in their career, in their life, and 85% of them will have recurrent episodes, meaning 72%, it turns out, have recurrent major depression. So the comorbidity is overwhelming, which is why the Mood Disorders Clinic has lots of people with borderline personality. So first, oh dear. Oh, maybe this will work. So you may wonder, I wonder, why it is we don't know more about this. We have hundreds of studies on depression, dozens and dozens and dozens of studies on bipolar disorder. There are somewhere around the low 30s, since DSM-3 came out in 1980, maybe 33, 34 RCTs on borderline personality. How is that possible, given how common this is in clinical practice? And it turns out it's a very difficult area to do research in. One is, we know that the personality disorders, the way they're represented in the DSM, is cluster A, B, and C, implying that within a cluster, there's a lot of overlap between one and another. Cluster A is the odd ones, cluster B is what we're going to focus on, cluster C is the anxiety ones. And the overlap means that most patients who meet criteria for one personality disorder will meet criteria for at least, usually more than one other one. So when you're doing a study, do you require just requiring the person to have that one disorder but not the others, like pure culture of? well, then that's going to be an awfully hard recruitment. So the overlap among personality pathology, which has given rise to many of our colleagues thinking we should be defining personality disorders dimensionally, not categorically. That is not you have it or don't have it, but how many criteria like height or weight as opposed to categories. So that's problem one. Problem two is most patients with borderline personality have a lot of axis 1 disorders, symptom-based disorders. In the CLPS study back east from 20-something years ago, the average patient with personality disorders had 3.5 different axis 1 disorders: mood, anxiety, substance abuse, etc. So given how comorbid and mushy the population is, it becomes awfully difficult to figure out what are you actually evaluating and treating. Third problem is what I think of as state trait problems. So you can talk about a major depression, active versus in remission. But by definition, personality disorders are enduring, pervasive, and stable. We don't have a really good way of saying where are they in the course of borderline personality, because you don't have an episode of borderline personality. That doesn't make sense. So what do you require for the patients to go into the study? Do they have to be symptomatic? And to what extent? The DSM is silent about that. The fourth is, for what is by definition long-term problems, personality pathologies, again, enduring, pervasive, and stable, almost all the studies are short-term, weeks to a few months. These are disorders that go on for decades. We don't have any treatment paradigms that go on for other than short-term. I'll show you a little bit more about that. So that's a huge problem, a gap in our database. The three other problems are, one is, the one, to get psychiatrists to agree on anything is difficult. The one thing we all agree on is that the way we define personality disorders in the DSM is terrible. That's the one thing we agree on. Categorical, dimensional, doesn't matter. We all think it stinks. And therefore, almost every author who does an RCT in borderline personality says, we use the DSM criteria, but with the following changes, because nobody likes it. Well, of course, that destroys the whole purpose of the DSM, which is about reliability. So if I say I treated borderline personality, you know what I meant. So this one with marked mood lability, that one with comorbid psychotic features, etc. And therefore that completely limits the generalizability of the studies, because we're all looking at different subgroups in these studies. And the last one is forensic issues. So if you were a young faculty member and you wanted to make your bones in our field, would you rather study depressed people who tend to be somewhat passive, albeit negative, and will sign your little informed consent? Or would you rather do studies on a group of angry, litigious people who are going to threaten you? Right? Who wants to do studies? This is a difficult population to work with, and it's much easier to work with other people than borderline patients. So we have 30 studies when we really should have 200. So I'm not a personality theorist, but if you think about what do we mean by personality? It's really about two dimensions. One is what you'd really call temperament, which is the biology or the core issues of how we function in personality, and everything else is learned behavior. Every psychotherapy is based on a theory of learning. Psychoanalysis is stuff happened to you when you were younger, and now you got these troubles now. Cognitive behavior therapy is your behavior is shaped by certain beliefs and experiences, etc. So those are all learned behavior. Do we believe in the biology of personality temperament? Of course we do. Everyone says, oh my God, I gave birth to my grandmother. Or, my sister is just like Uncle Harry. Well, hopefully, maybe not Uncle Harry, Aunt Mary. And so we all know that within families, there are certain personality characteristics that run in it, probably for genetic and biological reasons. Obviously, we know that, of course, with animals. You're not going to get a German Shepherd for the same reason you're going to get a Labrador Retriever, because we know that breeds of dogs have been bred to have different temperaments. The problem in humans, see, we're all mutts. We have all sorts of different ways of being with each other, and because we marry all sorts of different people and have co-parents that are different, we end up with not the same clarity that we do in the dog world, as an example. And you can think, well, maybe what happens when you give medications to people with personality disorders, that you're really targeting the temperamental issues, not the learned behavioral issues. Okay, that's reasonable, except it's a cartoon to think that those two aren't related. So as an example, we know the two examples. One, we know that in certain animals, if you blindfold the animals when they're pups, and then you take the blindfold away, they'll never see normally, because the visual cortex is being created already after they're born, and you environmentally change brain biology. We also think early abuse and neglect works the same way. We know from both primate studies, some human studies, that people who have early abuse and neglect probably alter their HPA, the hypothalamic pituitary adrenal axis, in a permanent way, such that as adults, they respond to stress differently. Environment changes core brain biology. So they're not as separate, temperament versus learned behavior, as you might think. They're clearly overlapping. The studies are pretty clear that the heritability of personality factors and disorders is in the same general ballpark as major depression, less than ADHD, less than bipolar disorder, but around the same as major depression. So temperament does indeed run in families for core biological / genetic reasons. And here's an example of this from a study from Sweden from 3 years ago. And what you can see is this is the hazard ratio, maybe a little hard to see. MZ, monozygotic twins, is the top, dizygotic twins, full siblings, etc. And you see almost perfectly that the less genetically related you are, the less likely it is that if one person has borderline personality, another one has. Showing, again, the classic way you'd show similar data with ADHD and bipolar disorder. The closer related you are, the higher risks you have for the same disorder. So conceptually, if you're going to think about giving a medication to a patient with a personality disorder, borderline patients is what we're focusing on today, there are 3 conceptual models. One is treating the disorder itself. That would imagine that you have an anti-borderline pill, which is kind of absurd on the face of it. We don't have any anti-borderline pills. So that's not the answer. Option 3, I'll get to 2 in a minute, is treating associated axis 1 disorders. Remember, I mentioned a few minutes ago that the average person with personality pathology has 3 to 4 different axis 1 disorders, symptom-based disorders. So really, when you're using an antipsychotic, a mood stabilizer, an antidepressant, are you really just treating the comorbid symptom-based disorders? Well, if that's all you were doing, this talk is over, and I've got 35 more minutes. So clearly, that can't be the right answer. The right answer is door number 2, second bullet on the slide. So the DSM has demanded of us that we think about treating disorders. Right, that we have an antidepressant because we're treating depression, and something to treat bipolar disorder. And what I'm telling you is the opposite. Forget about that. You're not, if you want to think about how to provide a medication approach to a patient with personality pathology, do not think about treating the borderline personality. What you're treating is the symptoms, the cluster of symptoms or behavioral dimensions within it. And I'll show you that on the next slide. So you're really treating symptoms, not disorders. Exactly the opposite of what the DSM demands that we do. So what are these behavioral dimensions? So again, if you look at the personality or psychopathology theorists, there are numbers of different ways of doing it. This is my favorite because it's the simplest. So it speaks to psychiatrists. This is from Seaver and Davis, who were in New York at Mount Sinai. They published this 34 years ago in the American Journal of Psychiatry. And they said, you can take all of psychopathology and reduce it all to 4 core dimensions. One is cognitive perceptual, psychotic stuff, depersonalization stuff, things like that, impulsivity and aggression, mood instability, and anxiety inhibition. And each of these dimensions cut across diagnostic lines. So impulsivity, aggression, you can see in schizophrenia, you can see it in mania, you can see it in antisocial personality, you can see it in substance abuse. It cuts across diagnoses. And so when you're thinking about treating personality pathology, you're not treating borderline patients, you're treating, it's actually B and C, impulsivity and aggression and mood instability are the core dimensions of psychopathology in borderline patients. So I don't know how to treat borderlines, but do I know how to treat impulsivity? I'll show you the data. The answer is I do. Do I know how to treat mood instability? I do. So again, you're focusing on dimensions of psychopathology, not disorders. Very, again, so different than what the DSM demands, the way it demands that you think. Just a word on the familiality, as it were, which includes genetics and environment of borderline personality. There's no doubt, as I showed you in that Swedish study, and in the family of borderline patients, you tend to see more borderline folks. Much to my surprise, and this goes against what I just told you, the sub-bullet, John Gunderson has this study, he is no longer with us, but in 2011, he published a study that seemed to show that all of the components of borderline personality really were due to one unitary construct. Very different than I was describing, but what I was focusing on is not the genetic issues. How do you think as a clinician as to what to do? So, but he says this is all part of a genetic disorder, and all of the subparts are genetically linked to each other with, again, heritability estimates similar to major depression. And as you might guess, anybody who's treated any borderlines or evaluated them knows that there's frequently, not always, but very frequently, a lot of early environment instability, abuse, neglect, chaos. That leads to very clear that if you look at twin studies, you see an amalgam of both genetic and environmental influences on the prediction of who's going to have borderline personality. All right, so we think about cluster B personality disorders, antisocial, histrionic, borderline, narcissistic. They're all kind of related to each other with the amplitude turned up or down, depending on which trait we're thinking about. The core dimensions for cluster B are, as I said before, impulsive aggressive behavior and mood instability dimensions. It's just how we define the cluster B psychopathology. In another study, John Gunderson, who was at McLean, he treated a bunch of borderlines and he rated their depressive symptoms and their borderline symptoms and looked to see, as they got better, which one was primary. And at least in this study, it's the only study of its type, he showed that patients, if you treated the borderline personality, did not treat the depression, as the borderlineness got better, the depression got better without you actually treating the depression directly. The opposite was not true. If you treated the depression with antidepressants or whatever, but you didn't use, in his case, an evidence-based treatment for borderline personality, nothing happened. His implication was that the borderlineness is primary and the depression is secondary. It's an interesting hypothesis. It's the only study of its type. It was in a psychoanalytic hospital, so there were biases there, but it's an interesting way of at least thinking about that patient population that he had. Second thing is, if you're thinking about the mood issues, the mood instability. So there are a lot of times people come to the mood clinic and we think, well, this is, they have a mood, an affective lability syndrome. Is this bipolar 2? Is it cyclothymic disorder? Is it borderline personality? And moods, not everything that goes up and down is borderline, is bipolar. Some of these people, of course, have other pathologies. The mood instability you see, really, if you think clearly about it, doesn't look like bipolar disorder. Borderline patients don't spend 4 hours, sleeping 4 hours, have tons of energy, and they're cleaning the blinds in the middle of the night. That's what hypomanic people do. Borderline patients, the mood instability is between anger or anxiety and depression, not classic hypomanic features. There's no elation. If you really do a good interview, you should be able to distinguish between those forms of affective lability. And we're going to talk a little bit about impulsivity and how to think about that both genetically and pharmacologically. I want to say just a word, even though the talk is about borderlines, about antisocial personality. You would imagine that given that antisocial personality features link very much with impulsivity, that we should have all this data on how to treat these people. In fact, we have none. There's not a single RCT in our field about a pharmacotherapy for antisocial personality. The problem is, where are most of the antisocials who are not CEOs or presidents of various things like that? And the answer is, they're in prison. And getting informed consent from an incarcerated population is ethically very tricky. There are, in fact, 2 prison studies on pharmacotherapy that I'm going to show you, but that's it. The entire literature is 2, one on lithium and one on an anticonvulsant. And I'll show you those data. But what you really want to distinguish, if you're talking about aggression, is impulsive versus not impulsive. So as an example of the biological differences from a study from 40 years ago on like fire setters. And there are 2 different kinds of fire setters. There are impulsive fire setters. There was a tragic thing in South America where some guy goes to a dance hall and a girl refuses to dance with him. And 10 minutes later, he comes back and he torches the dance hall. That's an impulsive fire setting. That person is likely to have low serotonin metabolites, central nervous system, CSF, 5-HIA, which is the major metabolite of serotonin. Second kind of fire setter is somebody who says, you know, my building, I have $1 million insurance on it, and my business is only worth $500,000. I'm going to decide to torch my building for insurance reasons. Now, that's also a fire setter, but that's not impulsive. That person may be an arsonist and a crook, but he's likely to have normal serotonin metabolites. The key is not the criminal behavior. The key is the impulsive aggressive behavior that we have a biology for. The planned out stuff, we don't have a good way of understanding that biologically, at least not yet. All right, so borderline personality is very common, both in epidemiological populations and certainly in treatment populations. And of all the studies in personality pathology with meds, 85% of them are with borderline patients. And that's because these people come into treatment, they kind of get attached to us, they don't leave, they're very difficult, and there's something biological smelling about them. Like they really don't have control over what goes on, the mood swings, the impulsivity. And we have tested almost everything: antipsychotics, antidepressants, mood stabilizers, omega-3 fatty acids, naltrexone, blah, blah, blah. And I'm going to go over all that. Okay, this is the core of the talk, which is what I think of as the central paradox. The central paradox is that every scholarly review and meta-analysis you will ever read in this area tells you, don't do it. Don't prescribe medications. And if you do one medication and do it briefly and then stop it. So the last 2 elite reviews in our field, one is in JAMA, one in Lancet, 2 of the elite journals in the field. The JAMA review published just a year ago said, and I took these direct quotes, psychoactive medications do not improve the primary outcome of borderline personality disorder. And the Lancet review published 2 years before said, quote, medications cannot be recommended for the treatment of borderline personality disorder, and quote, this is the biggest joke for those of us in the mood clinic, do not combine several drugs. Ho, ho, ho. So then, let's ask what actual clinicians do. The answer is clinicians do exactly the opposite of what these 2 elite reviews tell us to do. So again, Mary Zanarini is at McLean with the Gunderson group. She followed 362 hospitalized patients with personality disorders, and frequently patients were on 3, 4, 5 medications. So residents in the mood clinic don't feel so alone. Even in Germany, where they're much more concerned about polypharmacy as opposed to West Los Angeles. Even they average 2 medications. So the paradox is all the scholarly reviews says do not prescribe. And if you do, do it briefly and certainly don't combine meds. And that's what we do every day with all of our borderline patients. And I think the answer is we do it out of desperation. These are people who are suffering, they're difficult to treat, and we add medicines and we combine and we switch because we want to do something to help these people, despite the lack of data showing that what we do works. So, 14 years ago, there were 2 meta-analyses that went over all the studies. At the time, there were 27 RCTs that had been published. Now we're up to, I think, 33, 34. And as you can see, they're all short-term. The recent ones are all without patients. Some are pure borderline, some are borderlines plus other pathologies, and mostly they're teeny little studies. The only ones that aren't teeny little studies are those, not surprisingly, funded by pharma firms. What a shock. And I'll show you those data with, of course, large dropout rates. What else? So, and this is the summary of the 2010 review. What it showed is that what they did is they divided outcome variables into the, as I was showing you before, the dimensions of psychopathology: cognitive perceptual, impulsive behavioral, affective dysregulation or affective lability, and a global rating. And what you can see if you look across the slide from left to right, starting at the right, mood stabilizers win the game. The data were best for mood stabilizers, primarily anticonvulsants, not lithium. I'll show you that in a minute. With the largest effect sizes, antipsychotics had the second largest, and the antidepressants win B. Very good, very few good data showing that antidepressants help a whole lot with borderline personality. So that's 14 years ago. There are, forget the first generation antipsychotics, because other than the case we discussed this morning with tenofovir, we tend not to see those. Anyway, with clozapine, there are in fact 3.5 studies on using clozapine for borderlines, but again, these were borderline patients with added features. I have never prescribed clozapine for borderline patients. Clozapine is a very difficult drug as it is. So treatment-resistant bipolars, treatment-resistant schizophrenics, yep. Borderlines, nope. And the extra added features had comorbid psychosis or other severe disorders. They were not your everyday outpatient borderlines. And it seemingly worked. These were open studies. The most recent one is this Crawford study from 2 years ago, where their power analysis suggested that they needed 222 patients to do the study. And after years, they had 29 patients. Recruitment was basically impossible. So that's what I think of as a half study. So they published it, but it's a useless study. If you look at more recent, this is the more recent meta-analysis from 3 years ago. This looks at the antipsychotics. That's what it says. It should say at the top, excluding first-generation agents. So this is, risperidone, Abilify, olanzapine, quetiapine, etc. And as you can see, the p-value is 0.1. So technically, it says it doesn't work. I disagree with that clinically, and I'll get to that. There are 2 olanzapine studies. Olanzapine does not have the FDA indication because the second study was resoundingly negative, published by the inpatient chief resident of UCLA in 1977, Chuck Schultz. Anyway, this is the one where it was positive. This is out of the McLean group, and you can see both low-dose olanzapine groups did better than placebo. But the second study was a negative study, and the FDA did not give them an indication. Done. This is a positive study on quetiapine. Again, low dose, a la adjunctive antidepressant kind of unipolar doses, where 150 and 300 are basically equivalently effective and markedly more effective than placebo. But there are other studies that are negative. So overall, when you put them into a meta-analysis, it's unimpressively effective. Let me, go back. This is a recent negative study, except for the last week, a brexpiprazole Rexulti study. And again, the data overall show that antipsychotics work some, but unimpressively so. How about SSRIs? Well, again, I showed you the early meta-analysis that says that SSRIs were not particularly effective. Again, here too, I disagree. There were only 2 RCTs because by the time people were doing these studies, the SSRIs were basically generic. And so there was no pharma firm had a really good incentive to do anything. What I think works with SSRIs, and I'm going to go back to this in a few minutes, are really good for affective reactivity. How quickly and how easily do you get your feelings hurt related to neuroticism in the psychology world? SSRIs blunt that well. And I think that borderline patients who have that very specific sensitivity, somebody says boo, and their feelings get hurt and they take to the bed for a week. I think those people do well with SSRIs. But in the generic broad group of borderlines, it washes out with the larger group. So the data don't show it, but I think it works with a subset, and we'll get to that in a minute. MAO inhibitors, very tricky with MAO inhibitors, given the dietary thing. You don't want people to act out by eating Roquefort cheese and getting a hypertensive episode. We did have a patient in the mood clinic who did that 3 years ago. She actually bought a bunch of cheese from Trader Joe's and ate it and paged her resident and said, I'm in a park eating Roquefort cheese. And she refused to say which park. So of course he paged me. So we both anxious. Anyway, MAO inhibitors should work because remember, MAO inhibitors are highly serotonergic like SSRIs. How do you know that? That's why you can't combine SSRIs and MAO inhibitors, because you're increasing brain serotonin by 2 different mechanisms, which yields the risk of serotonin syndrome. Anyway, there are a handful of studies that indicate some real efficacy. But again, you have to pick carefully if you're going to give a borderline patient an MAO inhibitor. Why don't we know more about lithium with borderline patients? First of all, of course, you can't patent lithium because they come out of a set of rocks in the Atacama Desert in northern Chile. The Michael Sheard study from whatever that is, 40, almost 50 years ago, incredibly, is one of the 2 prison studies that I was alluding to. Take a bunch of prisoners, put some on lithium, put some on placebo, and it's easy to measure outcome in prisoners because, if you act out as a prisoner, there are very specific consequences. And it turns out lithium worked. This is one of the elegant early studies 50 years ago. The second study was from Canada. That's the Paul Link study. And the problem with that is the funders, the Canadian government, pulled the funding halfway through. So the N was too small to say anything. But that's the world's literature on lithium in borderlines. Horrendous. We should know much more. We don't. Anticonvulsants, I had told you that the meta-analysis clearly showed that as the primary, the most helpful of the medicines, and medications that have been evaluated are topiramate, lamotrigine, valproate, oxcarbazepine, trileptal, etc. And in that early meta-analysis, it worked like gangbusters for impulsive and behavioral discontrol. That intuitively sounds right to me and fits with my experience. Lesser effects on straight mood, but on the impulsivity, and remember, borderline patients are frequently impulsive, acting out with gambling, sex, drugs, anger, all sorts of things. It really worked. Unfortunately, there have been some negative studies more recently, and the 2021 meta-analysis, let me show you, where's that? I don't know where that went. The later meta-analysis didn't show any positive results because there were some negative studies. Nonetheless, in the mood clinic, we use anticonvulsants all the time for impulsive dominated borderline patients. Lamotrigine is the one we use the most. There were 2 earlier studies, small N studies, the Tritt and the Reich study, and then came this 2018 Crawford study published in the American Journal, which was very unfortunate. This was far and away the largest study of an anticonvulsant for borderline personality. And anyone see any room between the orange line and the green line? Raise hands. Dreadful. About as negative a study as you could get. Now, Let me go back. Now, there are, I mean, it was a reasonably large end study. It was published in the American Journal. But if you really look more carefully, only the third of the patients actually took the medications as prescribed. That would be a small problem. And you wonder whether these were kind of end stage borderlines, as it were. So even though this is the single biggest study and it's a negative one, I don't believe it. I really think that anticonvulsants do help borderline patients, despite this resoundingly negative study. If you add these three studies together, the Crawford study is so big that the PAWA, that's from Mayo Clinic, they did a meta-analysis and said, no, lamotrigine doesn't work. But it's really because the analysis is so dominated by this negative Crawford large N study. Topiramate, surprisingly, has been the topic of many studies in this area. There are 3 good double-blind studies, all from the same group in Vienna. Marcus Nickel seems to have cornered the market on Viennese borderlines, taking over for Freud, who died, actually went to England and then he died. Anyway, Marcus Nickel is the borderline dude for Vienna. He published 3 different studies, all of which are positive, and you end up third from the bottom, smaller borderlines. They will lose weight because topiramate is a weight loser. Anyway, it seemed to work. There are no good American studies with topiramate. I think it works, but again, you have the problems of sedation, the cognitive impairment, the paresthesias, the side effect profile of topiramate is problematic. So even though we have one set of criteria for borderline personality, one wonders, are there subgroups? I alluded before to how I might use anticonvulsants for impulsive dominated borderlines, and I might use for the rejection sensitive folks, serotonergic drugs. So somebody, this is actually from Paul Soloff from Pittsburgh, he said, you know, maybe what we should do is divide our borderlines into subgroups. And this is his typology. I'm going to explain it in a minute. And I think it's very helpful clinically, but look at the last bullet. Nobody's ever said, let's divide the borderline group into the rejection sensitive ones, the impulse laden ones, and use different pharmacotherapies and see whether we can subgroup them. Nobody's done that. That would be a great complicated study to do. So there are 4. This was published 30 years ago, so he used the abysmal name hysteroid dysphoria, the depressed uterus. For all the obvious reasons, hysteroid dysphoria morphed into atypical depression in the DSM-4 and 5. It's the exact same criteria with a much better label, but this was what he wrote in the late 80s. And he suggested that serotonergic drugs, SSRIs, probably SNRIs, MAOs, would be the right way to go, like rejection sensitivity, atypical depressive features. There, about 20% of borderlines also meet criteria for schizotypal personality. These are the people who have transient psychotic stuff or are disorganized. Maybe they live in Topanga, they have 12 cats, they collect string or aluminum foil, things, you know, little cluster A oddnesses. And for those people, maybe I hope nobody lives in Topanga. Anyway, for those people, antipsychotics might be the way to go. For the impulse-dominated people, the anticonvulsants strike me as the single best thing to do. Lithium, again, no data. Lithium would be reasonable too, given what we know about lithium and impulsivity. And the 4th subtype of borderline patients, he described as the empty depressives. These are the bottomless pits of need. People who burn out all their lovers, their relatives, and their psychiatrists and their therapists. Because no matter how much you give, it's never enough. And eventually people get depleted and exhausted and push the patient away. And we've all met patients like that. We don't have any biology on that. Nobody knows how to think about what you can describe as the empty depressives, but everybody in our field has seen some patients like that. This being a young, hip talk and audience, we have to talk about ketamine. Of course, how could you do a talk without ketamine? And people worry, oh my God, borderline patients, we should never use ketamine. Not true. There are 3 studies, relatively large N studies, on ketamine in borderline patients with depression. And in every one of them, they do the same as non-borderline patients. Remember, ketamine is not a psychotomimetic drug. It's a dissociative drug. It doesn't make people crazy. It makes them weird. And so these 3 studies, one is an IV ketamine study. The other one is where they took depressed people and simply subdivided them by whether they had comorbid borderline personality versus not. And lo and behold, borderline patients do just as well treated with ketamine for their depression as non-borderline people. So don't use that as an exclusion criteria. Most of the studies on impulsivity are actually not done with borderlines. And unfortunately, there's a huge literature, but it's not linked to DSM diagnoses. So all you can say is patients who have impulsivity were studied. And lots of people, lots of things work. Carbamazepine, phenytoin, dilantin, lithium beta blockers. The phenytoin study at the bottom is the second prison study. Very clever study. This is a prison in Illinois. And what you do is you give people phenytoin versus placebo, and you, as outcome variables, you divide the outcomes as to impulsive versus non-impulsive aggressive behaviors. So impulsive is, we've all had this experience, you're walking in the exercise yard, somebody bumps into you, you take the dumbbell and you clop the guy over the head. An impulsive aggressive response. The non-impulsive one is you're walking in the exercise yard, somebody bangs into you, you say, hey, that's cool, and 3 days later you knife them in the bathroom. So it turns out the first guy, the one who impulsively hits somebody in response, he's going to get more better from an anticonvulsant like phenytoin than the guy who plans out his revenge 3 days later. Again, remember my CSF 5-HIE study? It's not that anticonvulsants treat criminality or violence. They treat impulsive aggressive violence, not premeditated violence. Okay, and again, overall, not looking at borderlines, antipsychotics, anticonvulsants, just in general seem to work. All right, let me just keep going because I want to leave time for questions. So, how about SSRIs for aggressive impulsive behaviors? Well, there is some data, the first few studies on fluoxetine and paroxetine showing that they decrease impulsive aggressive behavior or suicidal behavior, which is frequently impulsive. But my favorite one is the third study. There was a joke for those of us who were around when SSRIs first came out as to what would happen if you give SSRIs to normals? Should we put it in the drinking water, is the way it was colloquially phrased at the time. And it turns out there's a whole literature on what happens when you give SSRIs to normal. The data are conflicting. My favorite study is this paroxetine study, the Knudsen study. So what you do is you go to San Francisco, and then you find 75 people with absolutely no psychopathology. How you could find 75 such people in the Bay Area is amazing to begin with. But let's imagine among the 770,000 people, you find 75 normals. And then you randomly, and these are people who have no psychopathology at all. And you put half of them on paroxetine, Paxil, 20 milligrams, put the other half on placebo. And then you rate the outcome. Now, those of you who know anything about studies say, well, wait a minute, how do you rate improvement for somebody who's asymptomatic to begin with? And the answer is, so psychiatry, we're only interested in pathology. Being asymptomatic is as good as we get. But psychologists have a broader range of interests. They're interested in shifts even within normal. So you use psychology scales because they show shifts. You know, a HAM-D score, what do you do if it's 0? You can't get better than 0. So they used a bunch of psychology rating scales, and lo and behold, people on paroxetine got better relative to placebo in 2 very specific ways. One in the study is called reduced negative affect and hostility. What does that mean? You're driving along Wilshire Boulevard. You are really late. The person ahead of you is driving 15 miles an hour on their phone. You say, as opposed to if you were on the paroxetine, you'd say, it's cool, I'm fine. I can wait. Doesn't matter to me if I'm. Now, having grown up in New York, I have absolutely no experience having that level of affect. The former is what I am. But nonetheless, people with paroxetine got less irritable in the stuff of everyday life. The second way is increased sociability. What does that mean? When we go to parties, most of us have a glass of wine or a single malt scotch. Why do we do that? Because we have mild social anxiety, and alcohol decreases our social anxiety. And then we meet a few people, we chat a little bit, we behaviorally desensitize, and then we're fine. That is an example. That's the minimum, a mild example of what you would do, where the more major example is social anxiety disorder, except you'd have 6 drinks because you're in a panic. And so what paroxetine did is it decreased normative social anxiety and made you less reactively angry. So what do you think? Should we put it in the drinking water? It's a good thought. Second study that I think is very relevant to SSRIs is the Harmer study. So reboxetine is a norepinephrine reuptake inhibitor. It's not available in the US, it's available everywhere else in the Western world. And there are tests where you show people really negative visual images, of war scenes and people dying and dead cats and stuff like that. And you can measure the startle response to this visual negative stimulus. And it turns out if you take normals, reboxetine, a non-serotonergic drug, has no effect, and citalopram does. It decreases the response to a negative affective image, exactly decreasing affective reactivity, except in a normative population. That's an example of how SSRIs can decrease affective reactivity. Obviously, when you're doing this, remember, borderline patients have high rates of comorbid substance abuse. You always have to be thinking about that. ADHD is relevant. There's actually a rat study that if you give rats stimulants, like you would college students, they have a decrease in impulsive behaviors. I don't know how you do that with rats, how you measure impulsive behaviors in rats, but they do so. So it's possible that stimulants can decrease impulsivity. Okay, so the last thing I want to say, well, next to the last slide, having done this for decades and decades, I am not naive about the effect of psychopharmacological agents on borderline patients. You're not going to, what you have to do is really set appropriate expectations. Nobody's going to get better. You're not going to give your borderline patient lamotrigine or oxcarbazepine, and suddenly they're going to turn into something incredibly stable, like a 3rd grade teacher or an accountant. That's not going to happen. But they may get less reactive, they may get less impulsive, and maybe instead of cutting, they're going to call their therapist first. That's a huge therapeutic triumph. So you have to help patients develop decreased expectations so they get better, but they're not going to get all better. And that's a critical thing that we have to do with these patients when you prescribe, to help them understand what to expect. Not magic, not everything getting better, improvement, and making them hopefully more workable psychotherapy patients, because that's probably the way to go. And obviously, compliance issues are a big deal. All right, so let me stop and then we'll open to questions. First of all, remember the conceptual framework for personality disorders is still in dispute. Dimensional is probably right, but it's really hard to operationalize that. That's why the DSM-5 is still categorical. Meds are generally not recommended, but we all do it. And I think we're right to do it because I think we have to. These are difficult patients who suffer, who make people around them suffer, and we've got to do what we can. Meds alone are not the answer. Meds plus psychotherapy, or therapy plus meds, probably is the better way to think of it. Anger, irritability, impulsivity, affective lability are the way to go, but we really should think about the polypharmacy issue. There's no doubt there are these patients of ours who are on 6 meds, and if you really think carefully, they're not any better on 6 than they were on 2. So we need to evaluate that. Because we need to know more about this, the TMS group now has a study on studying impulsive decision-making and emotional regulation in borderline personality disorder using TMS. So if you have borderline patients that you'd like to have be in a study of TMS, you should have them call 794-0339.
I have flyers.
And Dr. Luchter has flyers. Okay, with that, let me stop and we'll take some questions. Thank you.
I have one that I'd like to offer to open, and that really has to do with the natural history of the disorder, which I think you didn't have a chance necessarily to touch on. At various phases in our training, we're told borderline personality doesn't change over the life cycle, or we're told it burns out and gets better naturally, or we're told it gets worse. So which is true or is none true?
So from what we know, and there are a handful of studies, the best one is this guy, Michael Stone, who's a psychoanalyst at Cornell, who did a remarkable 20 to 30-year follow-up study on New York borderlines. They have a particular subset. Anyway, and what he showed is very much what you see with antisocial personality disorder. If you live through your 20s and 30s, the amplitude of the mood swings and the intensity of the impulsivity starts to get better after decades, not months and years. It's almost as if it's a delayed developmental disorder where the impulsivity that's common in adolescence gets better for most people, and in borderlines, it doesn't get better except 20 years later. It's not everybody, but frequently.
Dr. Martin has a question.
Yes, Dr. Martin.
Great talk. Fun to listen to, and scholarly at the same time. A difficult combination. Looking at all of this, particularly at the ending, it's possible that we're just measuring the wrong things in these clinical trials. That that these scales are missing things, because when you look at some of the measures that seek to deal with how people feel, sort of more patient-centered kind of measures, that maybe you would see outcomes that we're not getting from these kind of rating scales.
For those listening in, the question was, are we measuring the wrong things?
I would say that probably is as good an answer as to why the clinical community thinks these medicines work, and our patients think they work, and you can't see it in the studies. Exactly that. We may not be measuring the right variables in the study. And, again, because our diagnostic criteria, everyone agrees they're terrible. That's a real problem. I mean, we got to get symptoms right and the criteria right before we can start measuring change from treatments. I agree completely, Steve.
There's a question in the chat about whether and when to use benzodiazepines.
Well, those of you who've been in the mood clinic know that I am a benzo-friendly sanctuary city, I guess. You can do benzos in the mood clinic. I think if you're careful about who you pick, benzos can be terrifically useful. I mean, they're among the great anxiolytics that have ever come out. Less toxic than alcohol, less toxic than barbiturates. Now, certainly, if somebody had a history of sedative hypnotic abuse, that's a huge red flag, but not everybody has. And sometimes benzos can keep patients who get overwhelmed easily, and borderline patients are that. And if you calm them down a little bit with a PRN or even standing benzos, they can tolerate the stresses of life better. So I'm not cavalier about it, but I think with judicious use, they really can be helpful.
Question in the chat about why do borderline patients go off their meds?
Why do all psychiatric patients go off their meds? It's interesting. I'm not sure I know that borderline patients are less adherent than, let's say, bipolar patients. You look at the studies on adherence in bipolar patients, it's unbelievably bad. It's hard, especially for young people, it's hard to imagine that I need a medicine in order to function okay. That as adolescents, we want to think that we are the masters of our fate. It's only life that beats that out of us. So by the time you're older, you realize, you're not as much of a master as you think. But it's very hard in your 20s to know that if I stop my lithium, I'm going to end up in the hospital. Boy, is that a hard psychological task. And I think it's true for lots of young people.
Dr. Luker has a question.
Great talk, really enjoyed it. Your comments on patients with borderline personality not being bipolar. I agree with the sentiment, but to be devil's advocate for a moment and to invoke our friend, Professor O'Kistel from way back when, who talked about, patients with borderline personality being a subtype of bipolar, very different, changing much more rapidly, changing unpredictably, but perhaps a closely related mechanism. Why isn't that the case?
So what Dr. Luchter, the older, is describing is, I got the, Michael,
I
this for you.
prefer the senior to.
Excuse me, the more senior Luchter. Hagat Lakisko was a professor first at Vanderbilt and then at UCSD, who was very into an expanded notion of what bipolar disorder was. And there was a book in the 80s on borderline personality disorder, and he was asked to write a chapter. And basically the chapter said, this is stupid because there's no such thing as borderline personality. They're all misdiagnosed bipolars. Very much what you're saying. I, with all due respect, Dr. Kisko is no longer with us. I disagree with him. I think there are affective lability syndromes that belong in the bipolar spectrum and others that belong in the personality disorder world. I think it's too simplistic to call all of them bipolar. And if you look at family studies, in the families of borderlines, you actually don't see bipolar disorder. You see depression, you see substance abuse, you see impulsivity. Well, if it was really a bipolar subset, you ought to see an awful lot of BP1s and BP2s, and you don't.
We have time for one more question, please.
Debbie?
This concept at the end of the developmental nature by borderline personality disorder, I think gets to what you were saying, Dr. Martyr. It's so hard to measure these kinds of things. For instance, if the borderline personality person was abused, let's say at 3 or 4, like sexually abused, and the dose of sexual abuse comes out in how badly they cut themselves when they turn to adolescence. So from 3 to 14, they're not cutting themselves. At 14, they start cutting themselves. And the dose of how badly they were abused kind of determines how much they are doing self-injury. And also I, for a long time, because I think I was the person that tried to study borderline personality in academia, but could not. And
Tough to do.
But for a long time, I wanted to study because a lot of borderline personalities have nonverbal learning disorders. And so that's another developmental thing. And in the educational world, there's always a debate over whether any learning disorders are developmental. In other words, whether you're going to grow out of it eventually. And so that's just so interesting. Thank you for bringing that up.
Can I ask a question about the pharmacology of self-mutilation? So we've learned that self-mutilation is not only in borderline, but it's certainly a common symptom.
Correct.
Do you think of it in the impulsivity aggression spectrum, or do you think there is a unique way to think about self-mutilation and targeting with medications?
I think it's a combination. For those of us who've seen patients like that, and I suspect that's all of us, you know that some of these patients don't describe it as being self-destructive so much as kind of angst relieving. They say, when I cut myself, I feel better, which gives rise, and it was on one of the slides.
So we certainly don't want them doing that.
Well, we want them to
that
feel
was meant to be ironic.
We wanted to feel better, but without cutting themselves.
Yeah.
There was at the end, and again, I didn't have time to go over it. There's a small literature on naltrexone, the opiate partial agonist blocker, that may decrease self-injurious behavior. The idea being it decreases the reinforcing nature of it. I've had very mixed experience with naltrexone, but that fits with that hypothesis. So
it's a couple minutes after noon, so I think we should stop. But thank you for a really, really terrific talk.
thank you.